Have you been told you have bone-on-bone knees? Has a doctor used the words cartilage loss, grade 3 or grade for arthritis, or knee replacement and left you feeling like surgery is now only a matter of time? If you are nodding your head, I have great news. You do not have to make that decision today, and you may not need to make it at all. Here is the secret most people are never told. An X-ray can show you what is happening to the cartilage in your knee, but it cannot show you the one thing that actually determines how much pain you feel. The muscles around the joint. Two people can have identical X-rays, identical cartilage loss, identical bone-on-bone findings, and one is in constant pain while the other walks without a limp. The difference is almost always muscle strength. Today, we are going to build that strength, 3 exercises, under 10 minutes, no equipment. We are counting down from 3 to 1, and stay with me, because after the exercises, I am going to give you something called the 2-week test, a specific protocol that will tell you clearly whether surgery should even be on the table right now. Let's get started. This is important. Bone-on-bone is a phrase that means the cartilage between two joint surfaces has worn thin enough that the bones are very close together or touching. It looks alarming on an X-ray, and doctors use it to explain why the joint is painful. But here is what the X-ray does not show, and what most patients are never told. The cartilage itself does not have pain nerves. It cannot feel pain directly. The pain you feel comes from the surrounding tissue, the synovial lining, the tendons, and the nerves in the bone being overloaded because the muscles that should be protecting the joint have weakened. Now, here is the remarkable part: you cannot regrow cartilage. That is true, but you absolutely can change the way load travels through the joint. When the muscles around the knee are strong, they absorb force before it reaches the joint surface. When they are weak, every step sends the full shock directly into the bone-on-bone area. Strengthening those muscles does not repair the cartilage, but it can reduce the pain to a level where many people no longer need surgery. That is not optimism. That is what clinical research consistently shows, and that is what we are doing today. Let's start with exercise number 3, the prone hip extension. We do this lying face down. Lie on your stomach on a mat or a firm surface. A bed works if getting to the floor is difficult. Place your arms folded under your forehead or stretched forward, whichever is comfortable. Keep your legs straight, hip width apart. Now squeeze your right glute, the muscle in your right backside, and slowly lift your right leg off the surface. You do not need to lift high. 3 or 4 inches is enough. Hold for 3 seconds, then slowly lower back down. Completely release the glute. Do 10 repetitions on the right, then 10 on the left. Why do we do this? The glute controls what happens to the knee from above. When the glute is strong, the pelvis stays level on every step and the knee tracks in a straight, protected line. When the glute is weak, the pelvis drops on the unsupported side and the knee angles inward. An inward angling knee concentrates the entire load onto the inner bone-on-bone area every step, every day. This exercise targets the exact muscle that stops that from happening, and it does it with your knee completely offloaded. No compression, no grinding, pure glute activation. If lying face down is not possible, do this standing next to a wall. Touch the wall for balance, squeeze the glute, and lift one leg. Straight back. Same muscle, same benefit. Before we move to exercise 2, I need to tell you something that stopped me in my tracks when I first read the research. The British Medical Journal published an analysis of studies comparing exercise therapy to knee replacement surgery in people with severe knee osteoarthritis. The finding was significant. At the 2-year mark, patients who completed a structured exercise program reported pain outcomes that were not meaningfully different from those who had received surgery. Not slightly worse, not clearly inferior, equivalent. Let me say that again because it is important. For a significant proportion of people with severe knee arthritis, structured exercise produced the same level of pain improvement as surgery without the recovery time, without the surgical risk, and without the cost. Now, this does not mean surgery is never the right answer. For some people, it absolutely is. But it does mean that surgery should not be the first answer. It should be what you consider after you have genuinely and consistently tried what we are doing today. The 2 exercises I am about to show you and the protocol after them are built from this exact type of structured exercise approach. Moving on to exercise number 2, the supported wall slide. Now, don't let the standing position worry you. The wall takes most of your weight and the bend is very shallow. This exercise requires almost no balance and creates very little compression on the bone-on-bone area. Stand with your back flat against a smooth wall, feet hip width apart, about 12 to 15 inches out from the wall. Rest your arms folded across your chest or lightly on your thighs. Now slowly slide your back down the wall, letting your knees bend to about 30 degrees. 30 degrees is very shallow. Your thighs will be at only a slight angle downward. You are not going anywhere near a full squat. At 30 degrees, hold the position for 5 seconds, then slowly slide back up the wall. That is 1 repetition. Do 10. Let's do a few together. Slide down, hold 2, 3, 4, 5, and slide back up. Rest a moment. Again, down. Hold and back up. In this position, your quadriceps and glutes are both working isometrically, holding against gravity without moving. The quadriceps at the front of the thigh are absorbing the load that would otherwise travel directly into the bone-on-bone area. The glutes above are stabilizing the pelvis so the knee tracks in a straight, protected line. And because the bend is only 30 degrees, the compressive force on the joint surface is dramatically lower than it would be at 90 degrees or in a full squat. We are building the protecting muscles without loading the damaged tissue. A common mistake with the wall slide is sliding too deep. Deeper is not better here. Deeper means more compression on the area that is already damaged. Stay at 30 degrees. The benefit comes from the muscle effort, not the range. As a modification, if even 30 degrees causes pain, reduce the angle to 15, simply standing. With your back against the wall and tightening the quads and glutes without bending at all still activates both muscles isometrically. Start there and add a slight bend gradually as strength builds. As a progression, when 10 repetitions feel manageable, extend the hold to 10 seconds, then 15, increased hold time builds. The endurance these muscles need across a full day of walking and standing. My friends, before we get to our most important exercise, please take a second to hit the like button. It helps this video reach other people who have been given a surgery recommendation and do not know there may be another option. And if you have not subscribed yet, please do. We post new practical health guides every week. Thank you. Now we arrive at exercise number 1. This is the king of all exercises for bone-on-bone knees. I call it the load redistribution system, and I want you to understand why it is so important before I walk you through it. When you have bone-on-bone knees, the cartilage is thinnest in one specific area of the joint, usually the inner compartment, the medial side. Every time you stand up, walk, or put weight through the knee, the question is not whether the joint will be loaded. It is where the load will travel. If the load travels to the damaged compartment, you feel pain. The bone-on-bone area takes the hit. If the load is redistributed to the surrounding muscles and to the healthier parts of the joint, the pain reduces dramatically. This protocol teaches your body to redistribute that load on every single movement, not just during this exercise, but every time you stand up and every step you take. Once the pattern is learned, it becomes automatic, and the bone-on-bone area gets a reprieve it has not had in years. Step 1 is the position. Sit in a sturdy chair, both feet flat on the floor, hip width apart. Now, slide your feet backward until they are positioned just behind your knees, not alongside them, behind them. Here's why this matters so much. When feet are in front of the knees during a stand-up, the knee must travel forward over the toes to get the body weight balanced. That forward travel compresses the front of the knee joint, which in many people is the worst bone-on-bone area. When feet are behind the knees, the body can rise straight up with the knee barely moving forward at all. The load stays back, the muscles do the work, and the bone-on-bone area is spared. Keep your feet behind the knees every time, every chair. Starting now, step 2 is the hip hinge. From the feet back position, lean forward from the hips, not from the lower back. Think of the hinge point as being in your hip socket, not your spine. Lean until your nose is roughly over your feet. You will feel your weight begin to transfer into the soles of your feet. That weight transfer is critical. It is what allows the muscles to take over from the joint. Do not stand yet. Just feel the weight in your feet and hold there for a moment. Step 3 is the heel activation. Still in the hinged position before you stand up, press your heels deliberately into the floor. Feel the glutes engage. Feel the back of the thighs switch on. Now press to stand. Drive from the heels, letting the glutes do the lifting, not from the toes. When you press from the toes, the knee shoots forward and the load goes directly to the bone-on-bone area. When you press from the heels, the glutes and hamstrings absorb the force before it even reaches the knee. Heels into the floor, glutes on, then stand. Step 4 is the knee track. As you rise, keep the knees tracking directly over the second toe on each foot, not collapsing. Inward, not flaring outward, straight over the second toe. This is the most critical detail for bone-on-bone knees specifically. When the knee collapses inward during a stand-up, the entire load concentrates on the inner compartment of the joint. For most people with bone-on-bone arthritis, the inner compartment is exactly where the damage is worst. Tracking the knee outward over the second toe moves the load to the outer compartment, which typically has more cartilage remaining. It is the most direct way to take pressure off the damaged area on every single stand-up. Track your knees over the second toe every time as you stand to a full upright position, then pause for 1 second. Step 5 is the controlled lower. The way you sit back down is as important as the way you stand up. Hinge from the hips again, backward this time. Keep the heels weighted and keep the knees tracking over the second toe. Lower yourself slowly and with complete control, touch the seat gently. Do not drop onto it. Dropping onto the seat sends a sudden impact force directly up through the joint, which is exactly the kind of shock that aggravates bone-on-bone pain. A controlled lowering absorbs that force through the muscles instead. Now, let's put all 5 steps together for 5 complete repetitions, slow and deliberate. Step 1, feet behind the knees. Step 2, hip hinge forward, nose over feet. Step 3, heel activation, glutes on, press to stand. Step 4, knees over the second toe, pause at top. Step 5. Hip hinge back. Controlled lowering. Gentle touch. The heel activation fires the glutes first to absorb the initial push-off load. The hip hinge keeps the trunk balanced, so the knee does not need to travel forward to find the center of gravity. The knee over second toe tracking shifts the load toward the healthier outer compartment, and the controlled lowering prevents impact shock. The result is that the bone-on-bone area receives a fraction of the load it would normally. Do 5 repetitions in your exercise session, then apply these 5 steps on every single stand-up throughout the day, every chair, every surface, every time. Now, here is the technique that changes the entire conversation with your surgeon. I call it the 2-week test. Here's how it works. Starting today, do these 3 exercises every single day for 14 days. Apply the 5-step stand-up protocol on every stand-up throughout each day. Note 3 things honestly every morning. How long the stiffness lasts, how the first flight of stairs feels, and how many times you reach for an armrest to stand up. At day 14, go back to your surgeon or your doctor and report what changed. Be specific. How many fewer armrest reaches per day? How many fewer minutes of morning stiffness? That specific data will tell both you and your surgeon something an X-ray never can. It will tell you what the loaded joint feels like when the muscles are doing their job. If the 2-week test produces a significant improvement, structured exercise should continue before any surgery is booked. If after 14 consistent days nothing has changed, then you have genuine first-hand evidence that the conservative route has been tried. That is not failure. That is useful information. Either way, you go into that surgical conversation with data, not just fear. Here's your complete daily plan. Exercise 3, the prone hip extension. 10 repetitions each side, 3-second hold. Exercise 2, the supported wall slide. 10 repetitions, 5-second hold. Exercise 1, the load redistribution. System: 5 slow, deliberate 5-step stand-ups. Total time is under 10 minutes, once a day, every day for 14 days, plus the 5-step stand-up protocol on every single stand-up throughout the day. Before I close, I want to share something a viewer sent us. His name is Walter. He is 70, from Pennsylvania. He wrote, I was scheduled for a right knee replacement in 6 weeks. The surgeon said bone on bone, grade 4, no cartilage left. I found this channel, did the 2-week test, and went back to my pre-op appointment and told the surgeon what had changed. I could walk up the stairs without holding the rail. I could get out of a chair without my wife helping me. The surgeon moved my surgery to a watchful waiting category. He said he had not seen a response like that in someone with my X-ray before. Walter bought time and options. That is the whole point of the 2-week test, not to promise that surgery will never be needed, but to make sure that when you have that conversation, you have tried what the research says should come first. My friends, let's come back to where we started. You came to this video with a diagnosis: bone on bone, cartilage loss, a surgery recommendation. That diagnosis describes what showed up on an image. It does not describe what your body is capable of. Here is my challenge. Do these 3 exercises once today. Apply the 5-step stand-up on every stand-up. Repeat every single day for 14 days. Then come back to the comments and write your result. Write something like, started the 2-week test, day 14. Here is what changed, or simply still considering surgery, or canceled the consultation. I read every comment, and your specific result might be the thing that gives someone else the courage to try before they book. If this video helped you, please hit the like button and share it with someone who has been told they need knee surgery: a parent, a partner, a friend. They may not know that the research says to try this first. Subscribe if you have not already. New practical health guides every single week. If you want to go further, I made a video specifically about the exercises you can do from a chair when even these feel like too much. It is called the only 3 exercises you need for bad knees. Do these seated. I will link it right here. Take care of your knees. They have carried you through your entire life. Now it is your turn to carry them. I will see you in the next one.